As I was thinking about this conversation this morning, I was realizing that it was just over a year ago that I had been invited to join the American College of Medical Informatics meeting in Scottsdale, Arizona. It was the last trip that I've been on, and I've been basically in my home. I don't think I've been to another building in almost a year. And I didn't know what to expect with a group of medical informaticists, but Don Dentmer and Trent Rosenblum had invited me. And when I got there, it was to my amazement and relief to hear the empathy and understanding around this group of senior leaders in informatics. And I've put in front of you Don Detmer's title slide for the presentation that preceded mine. And the most memorable piece for me was hearing him say mea culpa and having that be part of the his presentation. And that gave me hope. And I realized that if we put our heads together, that those of us with a clinical background and those with an informatics background and others can come together and really achieve that vision of reducing documentation by 75% by 2025. And so I'm thrilled to be able to have been a part of this conversation over the last 6 weeks. In the next few minutes, what I would like to do is to share my reflections on what I've heard over the last 6 weeks. I've pulled out a few myths that I think contributed to our being where we are with documentation as a burden. I've also pulled out some bright spots that I heard during this series, and then some action steps that I think are required to really accomplish this goal. So without further ado, one of the other memorable things that I heard was from Zach Cohane, who said burnout happened on our watch. And with that, I also got that sense of shared responsibility for what's gone on. And we know we have a $3 trillion industry in healthcare that is underperforming. And in large part, it's underperforming because the individuals within are dispirited and in some cases despondent. And part of that is related to the fact that as clinicians, we often spend more time documenting care than delivering care. And that doesn't align with our mission. That doesn't align with why we went to nursing school or medical school or what other professional training. This is a picture from the Annals of Internal Medicine depicting the new doctor-patient relationship. And of course, where is the patient? We don't see the patient. We don't see the physicians talking to each other. It's a very siloed experience. And I believe that the burnout that we attribute to the impact of the changes in technology and healthcare come down to the fact that we realize that we are doing the wrong work, that we are spending our days doing the wrong work for our patients, and that we've become disconnected from our purpose. And that then has contributed to burnout. And I'll share the voice of one clinician and one patient here. The clinician: I am no longer a physician, but the data manager, data entry clerk, and steno girl. I became a doctor to take care of patients. I have become the typist. With that widespread understanding and experience, I think it's no wonder we have a $3 trillion industry that is underperforming. And here's the voice of a patient. On a recent visit to a new doctor, I believe we made eye contact twice upon her arriving and leaving. And yet I am much more able to receive advice from people I feel are thinking of me as a person rather than just the next patient. So I'd like to share with you some of the myths, or at least some of the components of the myth of the superhero, which I believe underlies some of the reason that we are where we are today. So what are those myths? It's this hero myth. One component is that clinicians can both do the work and document the work simultaneously, without any cost to patient safety, to patient satisfaction, to quality, to financial stability, or to professional satisfaction. So I believe that's a myth. Second myth, that clinicians can and should convert the clinical encounter into digital data for the convenience of others, whether that be the payer, the researcher, the accountability frameworks, that it's up to the clinician to convert that experience into digital data for others' convenience. And then thirdly, I think part of the myth of the superhero is this unspoken belief that our cognitive reserves are unlimited. But in fact, we know that our cognitive reserves are limited. We are human. And if we spend all of our cognitive bandwidth on the shallow work of healthcare, we will not have enough left for the deep work of healthcare. So those are some components of the myth of the superhero. There's another myth that I'd like to tag on here, and that is the myth that healthcare is really a series of transactions, and we can reduce healthcare into that series of transactions that can all be captured in a digital format. When I believe at its core, our work is relational, that we are in a relational business. And I don't mean that in a fluffy way. I mean that in a very deep way as well. I'm a better diagnostician when I'm doing that diagnosis on the basis of a relationship with a patient. I am better at therapy with the patient on that relationship. I'm better at working the system for the patient when I have a relationship with the other clinicians and staff with whom I'm working. So let's move away then from myths and turn to bright spots. And there were so many bright spots over the last 6 weeks, but the two I'd like to focus on are here. The first is Project Joy. Now, my husband calls me the Veep of Joy, so perhaps that's part of the reason that I was attracted to this title, but it really was the content of the work that Bonnie Adrian of UC Health shared with us. And as I understand, her team worked to reduce the burden of documentation for their nurses. They were able to eliminate 500 lines of data entry from the flow sheets that the nurses commonly used, that they saved 18 minutes per shift per nurse, that this resulted in a 21% decrease in documentation. They saved their organization $2.8 million a year in nursing costs. And most importantly, they saved 64,000 hours of nursing time per year. Imagine the amount of benefit to the community of having 64,000 more nursing hours available to advance health. So hats off to Bonnie and team. So the second bright spot is the Cliffbusters. And Adam Wright followed the presentation on Project Joy with his presentation on Clickbusters. And he reported being able to reduce the number of clicks by 10% in the entire system in just a matter of weeks. And they did that by having a process, but I thought that it was the tone that really was key to the success, that by respectfully engaging the workforce and humbly engaging the workforce and expressing gratitude, they were able to engage all in that work. So now some suggestions. I'll just share with you some of my thinking on this. First is to, excuse me, I need to make adjustment. There we go. Rethink documentation. We have nurses and physicians throughout the healthcare system who are spending hours and hours every week creating documentation that doesn't add value to the patient. Much of it never is read again. And we've moved so far away from the primary purpose of documentation, which is clinical communication and medical decision-making. So let's think about the purpose. Synthesizing medical thought. Bill Turney was active in the chat and really articulated several times how important documentation was, not for the act of documenting individual items, but for the act of synthesizing medical thought. The most important part of physician documentation is not documenting findings, but rather thinking, summarizing, and then retelling a terse clinical story. And also clinical communication. So I'd like to share with you documentation that comes out of my own practice. And this came from, this was the way most of the ER notes came to me in my practice. The patient presents with palpitations. The onset was just prior to arrival. The course duration of symptoms is resolved. Character of symptoms, skipping beats. The degree at present is none. The exacerbating factors is none. Risk factors consist of none. Prior episodes, none. Therapy today, none. That note went on. I'm sorry, I'm not getting advancing. Here we go. For 6 pages, but there was no meaning. What was the patient's story? What was the doctor's thinking? What care was provided? And so, like many barriers to both quality of care and satisfaction, the origins of this documentation are complex. But the end result was that there was a compromise in clinical quality, efficiency, communication. This was a note that most of you who are clinicians will recognize was composed by processing through a series of drop-down boxes. But it's more than just waste. The patient's story really matters. And I believe if we structurally ask our clinicians to do things like document through a series of generic drop-down boxes, we will not only begin to record the history in a generic way, we will begin to see and interact with our patients in a more generic way. So, more recommendations. Less is more. I really think that if we can document it with smart phrases and drop-down boxes, we should reconsider whether we should document it at all. None of us like to read through a maze of all that structured text output. It's a waste going in, and it's a hazard to the next user. The other piece I'd like us to reconsider is this notion that if it wasn't documented, it wasn't done. I think that's caused a tremendous amount of waste and harm and hazard, and we really need to get away from that. It simply isn't possible to document to a scale of 1-to-1 everything that happened within a human encounter, and then redocument it, and then document that at a scale of 1-to-1. So we shouldn't hold ourselves to that expectation. For our informaticists and vendors, I think we can easily eliminate 1 billion clicks a day. In my own record, it took 32 clicks to order and record having given a flu shot. And I know we can do better than that. I suggest we begin to socialize and normalize the idea of sludge audits. This is a term I picked up from Cass Sunstein, and he's written about this in the Harvard Business Review. And the idea here is to de-implement policies that may have made sense at one time, but are no longer needed, no longer up to date, or really didn't have an evidence base to begin with. We have to recognize that that sludge is not just something to shrug our shoulders at, but really is hazardous. Part of the way we're trying to get rid of some of that sludge at the AMA is we've created an initiative on debunking regulatory myths. And we have a page on our website where we currently have 7 different myths that are out there, because oftentimes something was well intended at the federal regulatory level, the EHR has enabled it, but then the problem is exacerbated by overinterpretation of those regulations at the local level. And so we identify the myth, and then we identify where in the Federal Register or in the Joint Commission's documentation we can debunk that myth. We brought together a group of compliance officers this spring at the AMA to hear about the world from their point of view. And we also shared with them the new model of advanced team-based care with in-room support. And one of the compliance officers said, you know, we've always been the people of no. I see now that we have to become the people of yes as well. So I'll end with a couple of these thoughts. And the one is that I do believe that over the course of my career, I have watched medicine evolve to a very transactional understanding of what we do. Tick boxes, shift work, discrete data, anybody will do. And yet, as I mentioned, I believe at our core that our work is relational and that the infrastructures with which we work, which include our technology, our staffing models, our payment models, need to support that relational conceptualization. And I believe we need to radically reorient the healthcare system around relationships to get the full value from that $3 trillion investment that we are collectively making. So, last takeaway, at the center of patient care are healing relationships between clinicians and our patients, and between clinical colleagues. And we need to not only normalize and recognize this, but build the infrastructures that support those healing relationships. And then finally, I'll leave you with the thought that I often leave people with, and it's a restatement of the quadruple aim. Care better than we've ever seen. Health better than we've ever known. Cost we can all afford. Delivered by professionals who find joy in their work as they commit to serve others. And I will tell you, it has been a privilege to work with this group of professionals, to be part of that vision, to create care better than we've ever seen, better health, lower costs, by professionals who really do feel empowered and fulfilled by the work that we all do. So with that, I want to thank you so much for giving me a chance to speak with you. And I will stop sharing my screen and invite conversation.
Oh, thank you so much, Christine. I think that was just a wonderful, amazing wrap up from our 6 weeks, and the chat has been quite active. So I think I'll start off with this question of, because there were a few notes, a few comments around this, separating out and to your points with the myths that you pointed out, separating out the needs of medicine from the need to getting paid via documenting the work, that you made the comment that less is more. There were comments in the chat that less is more only works if we have payment reform. And so questions around, reform to CPT requirements, AMA's commitment in that regard. And I wonder if you can just speak to this a little bit more.
Sure, I'm happy to. And I think what I'll do is address it in two domains. One is in the payment domain and the other is in the measurement domain. So in terms of payment, we really have something to celebrate. The 2021 evaluation and management coding changes that CMS announced that were part of AMA and CPT were part of that, although I personally had nothing to do with it. I think some of the best structural changes in healthcare that I have seen that will help us eliminate wasteful documentation. All of that documentation from the ER note that I read you was all about meeting bullet points for the history component of level of service determination. And in 2021, that is no longer relevant for billing. So we've already gotten relief for ambulatory and in the ambulatory setting for the documentation requirements for getting paid, because the history domain and the exam domain no longer count for billing. You just document what you need for your own and the next person's use. It's only medical decision-making. So I think that's just a stellar example of an improvement. And then less is more on a measurement. I think we have had this explosion of the measurement industry. And yet I don't believe that we have strong evidence that all of those individual measures have actually driven quality. And we can make the case that the burden of that measurement has actually been a barrier to quality. And so I think we have the opportunity to roll up measurement into a few limited measures. And the American Academy of Family Medicine, for example, has done that. They have replaced or suggested a replacement of something like 120 measures with 7 measures that will proxy quality.
Okay, great, thank you. And I think, and there certainly have been some comments in the chat, about the changes, to different coding and billing requirements too. I think, agreeing there. Wonder if we can just shift gears a little bit with a question. Again, to your point of less is more, and specifically, as you were saying, we should get rid of smart phrases and drop downs. We should, or when we have those, we should reconsider if we should document that information at all. Can you talk about that in the context that currently secondary use of EHR data really feeds many purposes, and one that was specifically called out in the chat is precision medicine. And so when we think about certainly research and where we want to, and the great things that we're able to do or begin to do, how would you align these kind of two ideas?
I think perhaps 2 ways. One is, I think we still need to honor that the clinician's primary responsibility is clinical care. And if the documentation burden is primarily to make it convenient for someone else to audit the record and extract from the encounter information they need for research or other purposes, we need to find some other way other than making the physician be the responsible party for that. The other is that much of the note bloat and the silly documentation that makes it a needle in a haystack kind of experience to try to find out what was the patient's story is not documentation that I think really drives things like precision medicine. It was documentation that was driven to prove a bullet point in the history or the exam. And so I think we can still have discrete data. Obviously, we need discrete data so that there can be sophisticated use of the electronic health record. But the way we've been documenting on these templates with drop-down boxes for duration, time, and context modifying factors for the presenting complaint has just created notes that are unintelligible. I have one more comment to make about less is more while you prepare for the next question.
Great, please go ahead.
So I think a lot of clinicians have had the experience now during COVID of sort of a new set of rules. And I've even heard people talk about COVID documentation rules. And I think what people are experiencing, and one clinic leader in particular said, her physicians went from hating their EHR to really appreciating it within a matter of days. During the first part of the COVID pandemic, when it was hitting hard, and this was in the Northeast, because they were no longer required to do things that clinicians saw as having very low value for them. Some of the documentation burdens that were lifted, and some of that was who could do medication reconciliation, who could do order entry, how much could you do a verbal order to get a chest x-ray, that sort of thing. And suddenly physicians felt like they were doing physician level work again. And we don't want to lose what we learned from COVID.
Great, thank you. And so, we don't have much more time. I think I'll just end with this thought and then your comments. There were comments kind of, reiterating, I think, statements that you made. We need to focus on this burden and challenge of finding things in the chart that clinicians encounter. But then there was also some comments around at the beginning of the chat, well, what about the thinking that is enabled by documentation? And I wonder if you can just end on that note.
Sure, I'm happy to, because I do believe that when, through my 32 years as a general internist, when I did and I dictated through the majority of that, dictated to a transcriptionist, so I could actually be thinking while I was doing this, that's when I was matching up the patient's illness script with the illness script itself, and I could match them and see, a 75-year-old with this, and this. Oh, that means that's more likely to be this illness. So it is a time of synthesis. But I think we lose some of that synthesis When we're also trying to edit the voice recognition output, I couldn't do that synthesis as well when I was doing that, and I could do it much less well when I was typing. And if we crowd out the time and the cognitive bandwidth on the shallow work of doing all the drop-down boxes, we don't leave room to do the deep work of the synthesis. So I think we do need to think about medical decision-making as one of the primary purposes of doing the documentation in its first place. But we've just pushed that way to the margin now for most clinicians.
Great. Well, thank you so much. You know, we are out of time because we want to have time for our breakouts. And Christine, I think on behalf of everybody on this call, I want to thank you so much for, you know, your participation throughout all the weeks, your active participation, and then your leadership and vision in really synthesizing for us, you know, what we have discussed and learned. And with that, I will pass it over to Peter as we transition to our breakouts to bring this information together and forward as we begin to identify actions that we really hope can move this work forward and continue this movement.